Good morning. The Tropical Health and Education Trust is a specialist global health organisation that runs and supports health partnerships between health institutions in the UK and in developing countries, which are managed by health workers and in which typically UK health workers volunteer to train and support peers overseas while themselves learning from the experience. THET provides funds and guidance through the DFID-funded Health Partnership Scheme, the HPS, which has been runs from 2012 to 2017. Chris Whitty spoke earlier about the difficulty of measuring progress in development projects. So I'm going to talk a little bit about our practical experiences of trying to measure progress in the HPS. Let me start with by giving you examples of a couple of health partnerships. A group of NHS trusts in southern England and Corlebu Teaching Hospital in Ghana have been running a project to develop multidisciplinary management of stroke patients. Health workers in Corlebu have been trained as stroke leads in clinical leadership and teaching skills. Corlebu Hospital has now opened a stroke unit and routinely provides assessment, management plans and multidisciplinary care for patients and has become an exemplar for stroke care in Ghana. Meanwhile, in the global midwifery twinning project, the Royal College of Midwives aims to strengthen midwifery associations in Uganda, Nepal and Cambodia. The Uganda Private Midwives Association has reported, for instance, that the project has helped us realise that we have been begging people to help us rather than having confidence in our message. The president of the Midwifery Society of Nepal has gained strength and confidence and been appointed to lead a new midwifery task force in the country, and UK midwives have trained nearly 1,000 colleagues overseas. So you can see that these are examples of the kind of intangible behaviour that Chris was talking about. So how do we define and think about progress in these kinds of partnerships? The theory of change is a useful way to start thinking about it. We expect that health worker training activities will strengthen knowledge and skills, leading to improved performance as long as other building blocks are in place. Or we might expect that stronger professional associations will go on to build continuing professional development programs that lead to better health worker education. We can say that relationships create social capital, that is opportunities, efficiencies, resilience, although it's very difficult to show them in any kind of linear fashion. So health partnerships have a range of results emerging over various timeframes. They may all eventually have an impact on the quality of health services, even health outcomes, but trying to measure that directly is futile in such complex systems. We have to think about our targets with respect to our interventions, not to overall development goals. So THET helped the health partnerships that we fund try to clarify their theories of change and measurement plans. The complexities of their project and their limited measurement resources meant that it was very hard early on to provide clear enough ideas of quantitative measures such as clearly specified performance indicators for trained health workers. And the data they came to report has so far been incomplete or required extensive interpretation or perhaps lacked baseline data. Now we recognise that forecasting results and setting targets is not easy in these complex projects. But we've realised that project plans must find a balance between precision and flexibility. We've started encouraging health partnerships to make plans and indicators as detailed and specific as possible, but to be ready to change them later on. We think it's more helpful to be precisely wrong than to be vaguely right. Data collection and management has been a challenge throughout the HPS. Even apparently simple data, such as the number of health workers trained, is complicated. How do you count the numbers mentored? How do you ensure data collection when trainees go off and run training courses elsewhere, which of course is great, is a great sign of sustainability, but can make data collection more difficult. We found that where there is very limited capacity for record keeping or audit, paying dedicated data collectors to work alongside the health workers is very effective. Collecting data on health worker knowledge and performance is harder, requiring observations of practice and facing challenges such as health workers moving on to other institutions before there is time to observe them. And data on organisational strengthening or relationship development is even subtler and trickier. Once collected, results data is very hard to interpret. These are complex interventions in complex systems with many confounding factors, such as the availability of equipment, movement of health workers, patient behaviour, and of course, we have no controls. These projects are not designed in that way. So we can't explain changes far down the theory of change, and we can talk at best about contribution, not attribution. Now, THET needs to measure progress at the programme level, that is for the whole health partnership scheme with its 80 projects in 26 countries. So we drafted a generically worded theory of change for the HPS, including results such as the number of health workers demonstrating improved performance. It has been a useful framework for communication and for guiding health partnership measurement, but even from the start we felt that representing the HPS in a simple diagram or matrix was like trying to squeeze an octopus into a box. It is possible, but it's hard to see the animal's true shape and capability. In particular, the theory of change glossed over the complexity and diversity of health partnership approaches and contexts, and implied that we could measure and aggregate their results easily. Now, I can tell you that 25,000 health workers have been trained in the HPS, but actually aggregating data across work streams is very difficult. A health partnership may run a short workshop for 20 health workers and send one on a month-long training course, and then aggregate that data as 21 health workers trained. It's like saying there are 21 pieces of fruit in this picture, without mentioning that one is a little different from the others. Aggregating data on outcomes is even less meaningful. Again, I can tell you that our health partnerships report that 4,000 health workers show improved performance. But how do you add them together? How do you add together improvements, different health workers, different techniques? Each health partnership in the HPS aggregates data across the work it's done. THET aggregates data from all the health partnerships that we fund, and of course DFID will go on to aggregate the data that we provide with the data from all the human resources for health projects it funds, all the health projects it funds, and so on. Each level of aggregation sacrifices detail and understanding for simplicity. When communicating progress, that is, there is a trade-off between meaning, detail, nuance, and simplicity, and it's not always acknowledged. Really, we need both quantitative and qualitative data to give a complete picture of a health partnership or programme. But once we've agreed to provide specific quantitative data in a development project, that becomes a measurement priority, displacing limited resources away from more meaningful measurement and learning. And at the same time, stakeholders may not be prepared to look closely at detail and nuance. They may want simplicity. Now, besides activities and results, we asked health partnerships to report their experiences and reflections from which we plan to produce good practice guidance. However, while we quickly identified common challenges such as maintaining communication between partners and dealing with the frequent movement of health workers, we were not easily able to elicit clear solutions. Principles such as it is important to consider power relations and resources when designing monitoring systems sound useful, but with contextual information filtered out, have little practical value. We feel that detailed, contextualised case studies engage readers more effectively and give them more ideas for solving problems in their own contexts. You're very welcome to read some case studies on the THET HPS website if you're interested. So we've changed our reporting requirements for health partnerships. Instead of asking them to give us a broad picture of their work, we ask for a few pieces of basic information and points of interest which we follow up in detail as appropriate. So I think we can say that in measuring progress, different contexts, different objectives, different stakeholders require different approaches. And so there are trade-offs. Rigour in measurement has a cost. There's a trade-off with affordability. Precision in analysis requires a close focus, so there's a trade-off with seeing the bigger picture. And simple communication means a loss of detail. There's a trade-off with meaning. We have to find a balance. And to find that balance, we have to remember, apparently the Americans have a phrase, you don't make a pig fatter by weighing it. That is, measurement is valuable not in itself but as a strategic tool. We must always ask, what measurement system will help us make good decisions and manage our work better? Thank you for your attention. If you're interested in working with us to address any of these challenges, we'd be delighted to hear from you.